All right, Amy, it's all yours. Take it away.
Thank you, Alyssa. Hello, everyone, and welcome to the Hirschberg Foundation for Pancreatic Cancer Research webinar, Two Perspectives, One Journey, Caregiving for the Pancreatic Cancer Patient. My name is Amy Reese, and I am the Patient and Family Support Coordinator for the Hirschberg Foundation. Aggie Hirschberg, our founder, is here too, and looks forward to saying hello at the end of the webinar. First, I'd like to acknowledge our wonderful sponsors who help make these webinars possible, including Celgene, Novacure, and FibroGen. Please ask your questions either during or after the slide presentation by clicking on the chat button at the bottom of the screen and type and submit your question. We will open the discussion for all after the presentation. This webinar is being recorded and will be made available on our website, pancreatic.org. I'd like to introduce today's presenter, Dr. Annette Stanton, who you may recognize as a moderator of our patient and caregiver panel at our annual symposium, as well as her talk titled Managing the Emotional Journey for the Pancreatic Cancer Patient. She's in charge of our research project, PACES, which stands for Patients and Caregivers Experiences Study. To say she's a friend of the foundation is a big understatement. Dr. Stanton is a professor of psychology and psychiatry, Biobehavioral Sciences at UCLA, and her research centers on specifying factors that help and hinder individuals as they adjust to health-related adversity. She's interested in testing theories of stress and coping in individuals and couples confronting cancer and other chronically stressful experiences. Thank you, Dr. Stanton, for joining us today. It's my pleasure to turn the mic over to you.
Thank you very much, Amy. And I am going to share my screen. Okay. And I think I will go ahead and share. Okay. Can everybody see that okay? Great. I really am very happy to be here today. This is a topic that is close to my heart, both as a researcher. As Amy said, I'm in the Department of Psychology. I chair the Department of Psychology at UCLA, and as a person, in that loved ones, very dear loved ones, have had or have had pancreatic cancer. As well as some other cancers in my life. So it's both personally and professionally very important to me. I also am, by way of background, I am a clinical psychologist and a health psychologist. So you could put it together to say I'm a clinical health psychologist, and I study I'm particularly interested, as Amy said, in understanding how people cope when they are diagnosed with a serious illness, and then what helps and what hinders them as they go along the journey. And in particular with pancreatic cancer and many other cancers as well, but I think that there's a particular experience of pancreatic cancer that very, very often is a very much shared experience. And so that's what I really want to talk about today. Probably at some point or many points, I will make a mistake and say the couple, but we are not, of course, always talking about a couple. Sometimes we're talking about the person who has pancreatic cancer and an adult son or daughter. Sometimes we're talking about a friend. Sometimes we're talking about someone else. So if I say couple, please understand my meaning broadly. And if I say patient, be assured that I don't see people with cancer as simply patients. People with cancer are people, and they are patients as they go to their medical appointments and as they are interacting with the medical system. But more than that, they are people living their lives, often with their partners and other loved ones. So what are we going to do today? Well, I often find it's most helpful when I'm thinking about chronic disease and pancreatic cancer specifically, to think about knowing what to expect, knowing what the person's experience is going to be, knowing what the partner's experience is likely to be, and then thinking about knowing what to do about that. So knowledge is power in this sense, both knowing what to expect and then having some techniques and strategies to know what to do about that. This comes from both my research and others' research today and my personal observations, both as a clinical psychologist and as a person who loves some people with pancreatic cancer. So let's talk about knowing what to expect. One of the ways we started out in this area, because primarily the cancer I'd been most focused on was breast cancer, and we've also done work in other cancers, particularly ocular melanoma or eye cancer. But when we first started out in this, we wanted to know what was out there in the research literature. And so my wonderful PhD students and former students and I conducted what's called a systematic review of 30 years of research, so 3 decades of research on patients and caregivers living with pancreatic cancer. So these are my wonderful students and former students, and I know at least one, James, is here today. It was published in the journal Pancreas. And so we actually combed through more than 7,000 articles because we wanted to get all the possible articles we could find on people living with pancreatic cancer. That yielded 36 articles. And one of my first points is that the research literature on pancreatic cancer and living with pancreatic cancer, the lived experience of pancreatic cancer, is actually very small. And there were only 7 articles that included caregivers. So this is a very small body of research, and it motivates our research. What did we find? Well, this is not surprising to you. Anybody who has pancreatic cancer or lives with someone who does knows that pancreatic cancer is a tough bear. It's in many ways more challenging than other cancers, both the lived experience, the treatment experience, and the trajectory. And so we found, and many of you wouldn't be surprised at this, so compared with adults who don't have cancer or what are called norms, so looking at the very large population of people who don't have cancer, adults with pancreatic cancer reported lower quality of life in several realms, particularly in the physical realm, their physical well-being, also in the psychological realm, and in the social or interpersonal realm. So that's probably no surprise to you. One exemplary study, and I wanted to mention this study because it did include caregivers, and this is one of the largest up till that time, which is 2018, that 70% of 136 patients and more than half of the 84 caregivers had quality of life that were below a local population norm. So we are talking about a disease that affects well-being in several different realms. We also found that compared with patients with other cancers, pancreatic cancer was a difficult bear. Pancreatic cancer patients had lower psychological quality of life in particular than did people with other cancers. Physical and social quality of life also tended to be compromised. And unfortunately, there were too few studies to really understand the quality of life of caregivers with caregivers of people with pancreatic cancer. But we're going to talk about that more as we go along right now. So first, let's talk a little bit about the experience of the patient with pancreatic cancer and the kinds of problems they are most likely to report at moderate to severe nature. And so here you see a slide, and this is from one of the only very large studies just published last year, so it wasn't even in our systematic review, and it was of 615 people with pancreatic adenocarcinoma. These were all people who were able to have their pancreatic cancer resected. So they'd had Whipples, partial Whipples, surgery to resect the cancer. Now that applies to obviously not even the majority of people with pancreatic cancer. So this is a particular sample, but it is a very large sample. And the three top problems that were reported at least moderately to severely as presence as a symptom were, for people with pancreatic cancer, were tiredness, problems with well-being, and lack of appetite. Those were the three problems most commonly reported at moderate to severe levels. You see the other problems here too: anxiety, drowsiness, pain, depression, nausea, shortness of breath. And so these are the kinds of problems that patients were experiencing. Caregivers, I think, really need to know that, what's most common. And you all who are caregivers on the call, I'm sure know this better than I do probably. This shows the same study, but differently. So the really interesting thing about this study, this is also patients who report at least one moderate to severe symptom, and this is over time. So this is a month after surgery through a year after surgery, 12 months. What you see here is what we saw on the last slide. Problems with tiredness and well-being were the most frequently reported by 60% or more at moderate to severe levels at first, and then they did get better in that first 3 months. They didn't, in general, get completely better. However, at 12 months, there were still considerable problems with tiredness and well-being, as there were with pain reported at a lower level and shortness of breath. And here are the other symptoms. Here we see right here, lack of appetite, very high initially as a moderate to severe symptom, getting better, but still remaining problems for many people. Depression, we see here. Drowsiness, we see here. Nausea, we see here. And anxiety, we see here. So those are the kinds of problems that patients are likely to experience in that first 12 months after surgery. And these are also problems that I've seen in patients, obviously, who are not able to have surgery. Now, this is a different study, and this brings in the caregivers. This is a study that was conducted by PanCan. Many of you have, I'm sure, heard of PanCan. It's an online support resource for people and loved ones with pancreatic cancer. This is from 2013, and this is 184 people who were diagnosed with pancreatic cancer and 213 caregivers. These are experiences reported as being experienced very often by patients and by caregivers. What you see here is that in this study, the caregivers were more likely to report these problems experiencing these problems very often compared to the patients. Particularly problematic for caregivers were worry, sadness, fear, and anxiety. You also see problems in both groups with tiredness, insomnia, nervousness, depression, and hopelessness. So caregivers are carrying an experience that is an important one, along with the people actually diagnosed with cancer. Now, I do have to say a couple of things about this. Often, it's the caregiver who is seeking support on PanCan. It's the caregiver who might be seeking information. So it's possible that these differences are larger than they typically would be. It's possible that it's the caregivers who are particularly distressed who are seeking PanCan for support, and they are the family information gatherer. And the people with pancreatic cancer who feel well enough to look for themselves on PanCan, seek support there, may be ones who are not as bothered by their experience with regard to their well-being. So I think we need to take these findings with a grain of salt, but I also think these findings show that this can be a profound experience and challenging experience for caregivers as well as for patients. This body of research did motivate our study, and Amy mentioned it, and I want to mention it again. This is called the Patients and Caregivers Experiences Study. It's possible that some of you have been in this study, and if you have been, I thank you for that. We are trying to understand the patients and caregivers' experiences living with pancreatic cancer. And when we get into the questions, you will see James McDonald, my wonderful PhD student, who is really taking the lead on this study. And you will contact him if you want to participate, and I hope that you do if you haven't already. And our goal really is to develop resources that will help caregivers and patients as they go on this journey. The study involves this is not quite right. The study involves an initial session. It has been conducted in person, but now we are conducting it online. And then 2 follow-up, either phone call or online sessions at 1 and 2 months after that. So 3 sessions, and we do compensate couples for their time with an online gift card. So far, we have 36 patients and 31 caregivers, and that is I can tell you that bringing people into this study is more challenging than I've experienced with breast cancer and eye cancer and prostate cancer, and I think that that's true because of the burden that pancreatic cancer places on people. And it's because it is such a difficult bear, people sometimes don't have the energy to participate. Sometimes they really they want to take part with us, but they're so involved in their chemotherapy, for example, or in their recovery from surgery that it's difficult. And so we've introduced a lot of people to the study and had about a third, a little bit less than a third of those participate. And we are welcoming continuing participation. If you're interested, you can call James McDonald, and you could email paces.ucla@gmail.com, and we will put those up for you, and maybe you can send them out to everybody who participated later on. I just want to tell you a little bit about what we found so far, and this is some interim analysis when we only had 26 patients and 23 caregivers. On average, patients were about 63 and caregivers were about 63 to 68 years old. We had a fairly even distribution of women and men, although women were more likely to be in the caregiver category. We had a fairly good distribution of people with regard to race, ethnicity, education. Most were married. And here we see the caregiver relationship at the bottom of this slide. People were most likely to be spouses or married or living as married, but there were also some adult children, friends, and there were some people who did not nominate a caregiver, and those people participate on their own by themselves, which is absolutely fine. Most people were not only dealing with pancreatic cancer, but were also dealing with some other physical problems, heart problems or arthritis, etc. And that was true of both patients and caregivers. And that's what you see in a group of people who are in their 60s and beyond. You can see the treatments here, and here surgery was overrepresented. So almost 70% of these small group had surgery. And that represents, we primarily recruit from the Hirschberg Center for Pancreatic Cancer here at UCLA. Most had been diagnosed on average for 3 years, but that ranged from 1 month to 16 years. And here's what I want to show you in this slide in terms of the difference between the caregivers and the patients. And that is patients reported considerably higher, caregivers reported considerably higher anxiety than patients. That did mirror the findings that I just showed you in the PanCan survey. Depression was not different, although caregivers reported somewhat more depressive symptoms than patients. Fatigue was not different, although patients reported somewhat more fatigue than caregivers. Pain was not different. And so here we're talking about people in couples or in caregiving relationships whose experience is substantially similar with the exception of anxiety. Now, this is a very small sample, and so we've expanded the sample already, and we're going to continue to expand the sample. So once again, I hope you contact us if you're interested, and Amy can send you that information. I do want to mention, before we go on to the what to do about it, I do want to mention a little bit about the important biology in pancreatic cancer. It does apply in other cancers, but particularly in pancreatic cancer. And two of my wonderful colleagues, Julie Bauer and Michael Irwin, here at UCLA, were authors of this review. And I want to specifically point out, and when I do this, do you see my arrow, the little arrow I'm using? Okay, good. Here are some factors about cancer and its treatment: the specific tumor, whether it's metastatic, having chemotherapy, the psychological stress that goes on with the diagnosis, having surgery and radiation. So all of these can contribute to biological processes. All of these can affect, for example, the sleep-wake cycle. So if you're experiencing fatigue and if you're experiencing insomnia as a patient, that in part can be a direct result of the action of the tumor. We know more and more in pancreatic cancer about the importance specifically of inflammatory processes. And you might have heard of pro-inflammatory cytokines. In general, pro-inflammatory cytokines are really good things to have because they're sort of the little messengers, part of your immune system. And if you get a cut, for example, pro-inflammatory cytokines are activated and they basically tell the rest of the immune system to come and help heal that cut. If they're activated chronically, however, they're associated with many, many chronic health problems. Problems with sleep, problems with cardiac dysfunction, problems with diabetes. Many problems result in part from chronic inflammation, when the inflammatory process doesn't know how to shut off, as it typically does when we get a cut. So these I want to say something because this is something important also for caregivers to understand. Sometimes the depression, the fatigue, the impaired sleep, the cognitive dysfunction, and this relates to one question we got for this session, the anger that patients can experience. Sometimes that's very likely to be connected to not anything that they're willing or not anything that is directly from their experience, but can be a result directly of inflammation. And so sometimes when patients, I had a very close person to me who had pancreatic cancer, and he was talking to me one day and he said, I don't understand it. I'm usually not an angry guy, and I find myself furious all the time. and I'm taking it out on people. I hate it. And we talked about how getting a diagnosis of pancreatic cancer can make you darned angry. And well, it should, because nobody deserves to get pancreatic cancer. Anger is an absolutely understandable response to pancreatic cancer. Another contributor could have been, can be, and I talked to him about this too, the inflammatory process that comes directly from the tumor and directly from the response to the tumor, as well as the chemotherapy that he was taking. So inflammatory processes can join with the experience to create potentially depression, fatigue, impaired sleep, cognitive dysfunction, and anger. So potentially what to do about it? Well, the first thing I want to say, and I say this in every talk I give, is that there is not a one-size-fits-all. There is no right way to cope with, on the part of either the patient or the couple. So anything I tell you today, I hope you hear that I'm not giving you a prescription. I'm not saying this is the right way to do it. I'm saying, what I am saying is some of the things that we've observed in our research, both with pancreatic cancer patients, but actually more with patients with other cancers, because I haven't been in the pancreatic cancer field that long. Also as a clinical psychologist and also as just a person. One needs to experiment and find your own way in terms of what's best for you as a person, as a couple, as a caregiver. That said, what we find typically in our research, and this is from many, many studies with people with cancer, primarily not pancreatic cancer, because again, there's a very small literature, but we're studying that right now, that avoidance doesn't help. And in fact, it can hurt. So trying to push thoughts or feelings away about the pancreatic cancer can be very difficult and actually make depression and lack of well-being worse. So we and others have found that even at biopsy, trying to push thoughts and feelings away before you even know if you have cancer, at the point of diagnosis, prior to and after surgery, and even 3 years later, avoidance early on can predict lower well-being, higher depression, higher anxiety down the road. That's not to say that focused distraction can't be very useful. It very much can. Everybody should have hours and days, I hope, where they don't think about the cancer. They can focus on something else. They're immersed in reading or something else, something fun. There's a particular process that we talk about in couples and in families called protective buffering. And this is when you try to guess what is going to upset, let's say, your partner, the person with the pancreatic cancer. And so you try to guess what might upset them, and you try not to do that. Same thing for caregivers with pancreatic cancer patients and pancreatic cancer patients with caregivers. So protective buffering has a really good intention. You're trying not to have the other person be upset. But it can also mean that you don't honestly communicate what your experience is. Because the more you try to protect the other one, the more it's possible that you don't really talk about your honest feelings and your honest experience. So protective buffering has good intent, but it can have a downside. Another study by Shelby Langer and colleagues showed that, and they took daily experience sampling for 14 days of couples, one of which had cancer. They found that holding back emotions, reporting holding back emotions, was associated with lower relationship satisfaction, on the part of both patients and caregivers. And so that sense of holding back can actually be more difficult for both the patient and the caregiver. That said, processes that approach the stressor tend to be more useful. Seeking information and resources. And here I have to say, for both the patient and the caregiver, one thing that can be really important here is that both of you, let's say we're talking about two people here, both of you are willing to accept the help of others. Because if you go into pancreatic cancer online, it can be a very difficult experience because you hear some of the most difficult statistics and some of people's very worst experiences. If you're going online, one, I would say go to trusted resources like the Hirschberg Foundation, like PanCan, like the NCI, National Cancer Institute. And it's also possible that this is something that a friend could do for you and transmit information to you as you want it and as you need it. So sometimes this is a role that caregivers give for patients, and sometimes it's great for a friend or somebody who knows about the medical system to do that. Actively accepting that you do have the disease, that doesn't mean that you're giving into it. It simply means that you're acknowledging that you have it. Acknowledging and expressing one's feelings, accepting support. This is something that's often very hard for people to do, but one of the things that I hope you learn as somebody who is a caregiver or is a patient, that accepting support helps people who are supporting you. They want to be able to do something. And so accepting that support, whether it's a meal or a hug or a distanced hug, can be very useful. Using spiritual resources, finding purpose. What brings you meaning in your day or in that hour that can bring you a sense of peace, calm, or meaning? That may be something small or something large. So I'm going to skip through fatigue to go to eating and weight loss because I really want to hear from Evelyn and Barbara. I do want to focus on eating and weight loss for a moment because that's a problem that is often, you see it in other cancers too, but it's more specific to pancreatic cancer. Weight loss is often a very common problem. And of course, we need to eat to survive, and it's better if we eat, if we don't lose a lot of weight. Some people with pancreatic cancer can lose up to 15% of their weight loss, of their weight as they live with pancreatic cancer. But this is a problem both for patients and for caregivers. So if you're a partner, I want to talk to you for a second. Food helps us survive, but it very often is associated in our lives with reward. When we came home from school, what did your mom or your dad do for you? They gave you a snack. When you go to your grandmother's house, does she say, oh, I made X and Y for you? Food gets not mixed up. Food and caring often go together. Food's often an expression of caring. And often the person who is the caregiver really wants to do something for the patient, and they really want to care for them through food. They also see them losing weight, and they're worried about that. So often the partner takes on the responsibility of helping the patient eat. That can be useful, but it often can be a difficult thing because even though patients want to eat, they'd like to eat, they would love to have an appetite. There are characteristics of pancreatic cancer that often, and also characteristic of the treatment, that often have as a result having no appetite or very little appetite and having nausea. So we all have the experience of nausea and know how very difficult it is to eat during that time. And so patients who have nausea and no appetite, it's not that they want to have those, it's not that they don't want to eat, they really do, but it can be very difficult to do. So there are tips that caregivers can think about and patients can think about. These are recommended by nutritionists. I am not one myself, so I'm not an expert, but the things like this, eating small high protein meals every 2 hours, storing small servings of food. One of my friends kept a protein bar by his bed because when he'd wake up in the night, he'd just have a bite of a protein bar. Take advantage of any appetite you do have. Don't eat your favorite food when you're nauseated, because then your favorite foods become associated, they become a condition to nausea. You don't want that. You want to eat the favorite foods when you're feeling a little bit better. And if you're nauseated, eat in a cool room and away from smells of cooking, because those things will help with getting food down. Emotions are also a dyadic issue, and we need to understand that a partner can't be all things. Listening, sensing that one doesn't have to fix the problem, but sometimes just listening is good. We had a question about the Kubler-Ross stages of grief. Do these apply to the pancreatic cancer partner and the patient as well? You see them here. The research shows that these are all common feelings. One that's missing, very importantly here, is anxiety. And another thing that's very important finding from the research is that not everybody feels all of these. Some people never feel anger, and that's okay. Some people don't get depressed, and that's certainly okay. But it's possible that both caregivers and patients can do most things, can experience these things, and to listen to each other and to ask, what's going to be most helpful to you? Do I just need you to listen this time, not try to fix anything? Or can you help me try to fix it? Those are some thoughts. I went over the time I meant to have. I want to acknowledge many of my collaborators. This is one of my loved ones who is diagnosed with pancreatic cancer, and these are my lovely daughters. And I want to thank the Hirschberg Foundation, obviously UCLA, and all of you. Now, I'm going to stop sharing. And I want to introduce first Evelyn. Evelyn is a 5-year survivor of pancreatic cancer. And Evelyn, I wonder if you have comments or thoughts about having a caregiver and what helps, what is not so helpful. What are your thoughts for us today?
Well, definitely I was a lucky one because my husband was retired when I was diagnosed. So he was with me 24/7. And I really, it hit home when we attended the Hirschberg Foundation seminar and you were a speaker. And I remember Amy was sitting, I think, behind us. And so many things that you said was what Bill did for me and what happened to me. And I kept elbowing him or tapping him on the shoulder or whatever through the whole time you were speaking. And I realized how important it is to have a caregiver. And like I said, I was very fortunate that I did have my husband. And I think it's important that people know what to expect, because he didn't, I didn't. I'd never been sick. I was 60 when I was diagnosed and had never been in the hospital other than to be born. So illness was not something that we really had dealt with our whole married life. And I was surprised how, I think it was with the PACES interview that we went to down at UCLA, and they had you write little answer questions and then went out of the room and you talked about it. one of the things that Bill had written down was that he was worried about me making it to the 5 years. The 5 years in his mind was something that I had no idea. I mean, when I had my Whipple tumor was gone, I was on my way, I was good. I didn't think about, am I going to see tomorrow? Am I going to see tomorrow? But evidently my caregiver, my husband, did. And I think that helped, having that for us to be a part of. And just everything that the Hirschberg Foundation has available and a big piece, I think, is having somewhere for caregivers to go to read about. One thing when you were talking about also weight loss, I mean, I'm basically a 140 girl and I got down to 115 and I think I was in 3rd grade. But this is so helpful for caregivers to know what to expect and how to help. And I was very lucky, and I know that. And almost 5 years, February will be 5 years. So I guess at that point, Bill will be feeling better too. But I want to thank you, because when you did that talk at the Hirschberg seminar, it was just so heartwarming and just hit home.
Thank you, Evelyn. That means a lot to me to hear that. And I'm so glad that you're doing so well now.
Pudged up again.
And obviously, when we have a time to chat, you can direct questions to Evelyn as well. But now first I want to introduce Barbara. Barbara and her husband, Lee. Lee was diagnosed in the year 2000. And Barbara has been right there with him all along the way, all along during that time. And so, Barbara, I'd love for you to share your thoughts.
Thank you. Surviving for Lee, for me, didn't come easy. There were a lot of anxiety-filled moments and a lot of months of just doing one day at a time. Lee is a survivor now for 20 years. A few things are different now from all those years ago. It took an agonizing 6 weeks to get a diagnosis, meaning much pain for Lee and lots of research for me. Finally, a diagnosis and surgery. A Whipple resection was scheduled for 5 days later. At the time, surgery was considered the first option. There was little information on the web at the time. However, I did find a website that said, foremost, you must locate a surgeon who does many of these surgeries. And the maker of the website listed all those surgeons in North America whom he felt qualified. There was Dr. Reber at UCLA. Before Lee awoke that Monday morning, I had an appointment with Dr. Reber and checked out a whole bunch of things. I cried in Dr. Reber's office. Oops, I might cry now. It was good news. We had a plan that was hopeful. The first surgery found the tumor unresectable. Terribly sad, I cried. Then we met Dr. Isaacoff, who enrolled Lee in his clinical study. Markers dropped and Lee seemed on the mend. He seemed almost well. We got a kitten, a therapy kitten, who was more than a distraction. I knew Lee would have a companion while I worked, and he made us laugh. Lee's chemotherapy was via a pump, and he went to work during the entire 6 months of that initial chemotherapy. During that time, we were married. After so many years together, it was important to me, and maybe even more important to Lee, and the future seemed bright. The second surgery was a successful Whipple. Much happiness, but there was a big bump in the road. His stomach was not working for 5 whole months. During the first 35 days, he was hospitalized. I fed the kitty, went to work, drove to Westwood, walked the hallways with Lee and his tree of multiple pumps, returned to Silver Lake, fed the kitty, and slept. That's it. No going to the gym, as I had been doing all the time. Life changes when most of the socializing is around food, and you don't know when he will ever eat again. I became depressed. And for the first time, I took anti-anxiety meds. During those 5 months that Lee was not eating, I dressed his multiple wounds. When Lee's stomach started working, that was a glorious day. And guess what? I stopped those anti-anxiety meds immediately. There was another 6 months of chemotherapy and consistent good reports from doctors for all this time. Life became more like it had been. How did we find our way through all this? There were few questions about what to do. We focused on what had to be done. Most important, picking the right oncologist, the right surgeon, those who have had multiple successes with your disease, be it pancreatic cancer or something else. Pick those whom you can have confidence in. So hopeful to caregivers at this time that there are so very many resources like Hirschberg Foundation, PanCan, and so many websites that actually talk about what to expect and what you might find along the way, and give so very many helpful hints, clues, and resources. Thank you.
Thank you, Barbara. That was lovely. Now, do we have questions? I haven't seen.
We don't have questions in the chat room, but would anyone like to ask a question? We do this rather informally, so either raise your hand or we're happy to continue sharing. Dr. Stanton, that question that came through from the participant, you sort of touched on it, but maybe I should read it again.
Yes, why don't you? That'd be great.
Okay, so one of you asked, said, we all know there are stages to grief, as Elizabeth Kubler-Ross explained. Are there stages after diagnosis of the disease, like pancreatic cancer? What tools can we use to assist us? And lastly, how effectively can we
what are you looking for?
and how effectively can we deal with anger from patients to caregivers?
Okay. In terms of the stages, what we know from the research is that the experiences that Kubler-Ross talks about, the denial, the anger, the bargaining, the depression, the acceptance, those are common experiences. And so it is, there is evidence that both patients and caregivers do have those experiences commonly. But there is no strong evidence that they happen in stages. There doesn't seem to be evidence that first you go through denial, and then you go through anger, and then you go through bargaining. So a stage model is not very well supported by research, although those are common experiences. In terms of dealing with those, another couple of points. Anxiety is missing, and it should be in there because that's a very common experience, particularly of caregivers of patients, but pancreatic cancer patients, but also of patients. Not having the experience, any one of those experiences, does not mean you're doing something wrong. Many people never get angry. Many people never go through that bargaining phase of, oh, I'll be a good person if you'll only let me be cured of this disease. So many people never go through depression, although depression is higher in people with pancreatic cancer than people with other cancers. We talked about that. Then what to do about it, and then anger specifically. So the resources that are available are, the Hirschberg Foundation has some wonderful resources. PanCan has some wonderful resources. There are effective treatments for depression, for example. Some of those are pharmacologic. You might want to think about some of those, you know, a medicine that could help you. Some of those, many of those are talk-based therapies and skill-based therapies. A therapy called cognitive behavioral therapy is an evidence-based therapy for depression. Some of the, what we might think of as newer therapies, mindfulness therapy, for example, has a growing evidence base. If we're talking about fatigue, and fatigue is a big problem, we saw that. We're talking about fatigue, and that's not in Kubler-Ross's stages, but it's important for people with pancreatic cancer. If we're talking about fatigue, the best treatment, actually, it's not a sleeping pill. The best treatment and the most enduring treatment is something called cognitive behavioral therapy for insomnia, CBTI. And one of the good online versions of that is called Sleepio, SLEEPIO.com. There are other online versions of good cognitive behavioral treatment for anxiety that are free or low cost. They come as apps or they come on your computer. So there are many evidence-based treatments. Those are just a couple of them. Anger, as we said, can come from those pro-inflammatory cytokines that we talked about, or can come from having the disease directly. Having the disease as the experience. Nobody would want to have this. So anger, how should the caregiver deal with it?
Yeah.
It may be really useful for the person with pancreatic cancer to talk to someone else about it, to talk to a professional. That's what my friend did that I just told you about, because he didn't want to take it out on his family, and he really didn't want to talk to his family about it. He talked to a professional. He actually ended up he saw a psychologist for a bit, and he also talked to a rabbi. Both of those were very helpful in putting the context of the experience and understanding his anger and helping with it. There are also some other behavioral anxiety reduction programs that you can try. There are a couple online. If a patient gets angry at you, sometimes it's really good just to both agree to take a break, go into separate rooms for a moment, do breathing, breathe, both of you, and then come back at a time when you can talk about whatever the source of the anger is. So those are some quick ideas.
Thank you. Also, Will asks an important question. Any guidance on how children are impacted or strategies for them? Mine are age 18, 23, 26, so none are very young.
Okay. I'm wondering if Barbara or Evelyn have children and had an experience with that.
Our only children have been cats.
And cats have been really important. Evelyn, you?
Yeah, Mike, the son, but he was older. He did, he handled it pretty well because, I don't know, maybe because he was older, but yeah, I think Mike did okay. There was no magic. I can't think of anything we did that was different other than just and everything, and make sure that he understood, what I was going through, what was going on.
Did you? And so you did talk
minutes from us, so
you did talk to him openly about it.
Oh yes. Oh yeah, very much. So, but like I said, he was even older,
Mm-hmm.
So
one of the, Will, your children are older. They're 18, 23, and 26. That doesn't, even children 18, 23, and 26, sometimes parents really want to protect them. It's that protective buffering we talked about. So you want to protect them, and that's a good intention. But what research finds in talking to children, even of that age, but also younger children too, to tell them, almost all children, no matter what age they are, if something's wrong, they sense it. They know it from you. They know somebody's going to the doctor more. They know somebody's going, not feeling well. And so keeping it a mystery is actually more difficult on them than telling them in an age-appropriate way that, what you do have. I have pancreatic cancer. This is what's going to happen. This is a serious cancer. And we're doing everything we can, use the words to tell them. They may also engage in protective buffering with you. Children react differently, even older children. Some want to talk about it, some really don't. Some want to do everything they possibly can for you. Some are so upset that it's difficult for them to really talk about it or think about it. So kids, even adult children, are difficult. Keeping it a mystery actually is one of the more things that can be difficult. So being able to tell them straight out. My son-in-law had glioblastoma, brain cancer, about 3 years ago. He's doing well now, and they had children who were at that time 5 and 8, and they told them, Daddy's sick. They're going to go in and they're going to take out that sickness. And so when Daddy comes home, his head's going to be shaved and he's going to look a little bit like a monster around here because he had a big scar. And then, and they told them that in this is what happens. They told him he was sick. They gave them good reason to think he'd get back to normal, which he has, but that he sometimes would get more tired than usual. And so sometimes they need to let Daddy rest. So that's to a 5 and an 8-year-old. But 26 and 28-year-olds also can have tremendous anxiety and not know what to do. One thing you can do for them is tell them what you would like specifically for them to do for you, because they want to do that. So those are some ideas.
Wonderful, thank you.
Thank you, Will.
We have a question that was posted on Facebook, and it is from Marie, who writes, I'm a caregiver. My husband, 37, and I just received the notice he has metastatic in his lungs. I am trying to support him, but it's not easy for him to accept he's not eligible for a Whipple anymore. And so she's asking sort of for some recommendations. And then I think to the larger group, if there are any support groups that others know about for non-Whipple candidates. And she also says, thank you very much for all of your explanation.
Can we ask, is this somebody who's getting treatment at UCLA or elsewhere?
Let me see if she replied. I am not entirely sure, but
if you and your husband happen to be at UCLA, there is a free cancer support service called the Simsman Center for Integrative Oncology. Anyone, any cancer patient seeing anyone at UCLA, even one of the satellites, there are many UCLA satellites around the around the Los Angeles area. That's a free support service, and so definitely they can go there. Amy can tell you how to connect with Simsman, the Simsman Center. Amy, you might want to talk for a second and tell about resources, and then we'll tell a little bit about the metastatic lung.
Yeah, I mean, I would love if anyone reaches out and wants me to give them information about support groups between cancer support, Cancer Support Community, which has a number of offices, Cancer Care. We're associated with Cancer Care, and they have online support groups and telephone support groups and other counseling. American Cancer Society. Depending on where you live and where you are, please feel free to reach out to me, Amy, amy@pancreatic.org, and I'll put my information in the chat.
Okay, again, that's Amy, amy@pancreatic.org. And I'm on the research board for the Los Angeles Cancer Support Community, and that's also a wonderful resource. And they are doing lots of online groups now, and they usually have in-person groups, and now they are doing many online online groups. And James, you can just nod. Is the Simsman Center doing lots online now? Yes, yes. So both as talking to people individually, as couples, and in groups. So I would recommend that. I'm not a physician, and so I can't and shouldn't comment specifically on having metastatic disease to the liver. But I do want to emphasize what Barbara said, and that is, I hope you're at a treatment site where they do many procedures, where they see many people with pancreatic cancer, and where they have the full range of treatments, because there are new treatments coming online. It's true that if you have if the disease is of a particular nature, it rules you out of some treatments. It also rules you out of some clinical trials, for example, of particular therapies that are newer. But I just want to make sure that you are set up with wherever you're going is a place that has a specific emphasis in pancreatic cancer. I want to really reinforce what Barbara is saying about that. And again, Amy can give people resources about the sites across the nation about that. What is a Whipple? A Whipple is a particular form of surgery. It's called a Whipple procedure, and that's what it's typically named. But it involves taking out much or all of the pancreas, as well as it can be very extensive surgery. And if you're, I'm sorry, was there a comment? It can be a very extensive surgery. And so, for example, the people in our study, most of them have been able to go through the surgery. But being able to go through the surgery depends on how much the cancer has spread. Has the cancer spread to other organs? And a lot of different characteristics about your particular cancer. So you should definitely talk with someone about, a professional about your treatment options. That's the most important thing you can do.
I also just wanted to point out that Gina, who is participating and also watching on Facebook, mentioned that she is a caregiver to her husband, who is a stage 4 pancreatic cancer patient, and she is happy to connect with anyone. So Amy and I will work to connect those people on this webinar who want to be connected. So if you're interested, just let us know and we'll work to make those connections happen.
Okay, I think our time is pretty much over. I'd like to say a few words. First of all, Annette, it is an absolute blessing that we met at UCLA, and you are a part of the UCLA Hirschberg team for pancreatic cancer patients. I mean, if I look at Barbara, I know that you were 20 years. I was a caretaker 23 years ago, and there was no psychosocial help of any kind. And most of the doctors felt that they could take care of every single aspect of your life. And it's just wonderful to see how we have changed over the years. From my personal experience as a caretaker, I think the key, and you mentioned it, is accept help. And when you mentioned that, Annette, I just, I know that was very difficult for a caretaker. I don't know, Barbara, if you agree, but but you have to accept help and welcome help, and not say I can do it all by myself. But Evelyn, you are wonderful, and I'm going to see you soon. And just
Thank you.
very, very nice of you to share and giving us your time. I think everybody learned. James, we're going to be in contact with you because we do want to be more aggressive about the studies that we should be doing. So with that, I'm just grateful that we had this day, and see you at the next one.
Take care, everybody.
Thank you, Aggie,
Thank you.
Amy, Lisa.